Black women really are strong, but it's a terrible strength.
This is the Visible Voices podcast. I'm Dr. Resa Lewis, emergency medicine and lifestyle medicine physician, medical educator, and your host. This show is about making healthcare more equitable, one visible voice at a time. Today, I'm joined by Dr. Kemi Doll, a gynecologic oncologist and health services researcher. Kemi has focused her career on the disparities in Black women's gynecological health. She co-founded ECANA, the Endometrial Cancer Action Network for African Americans, and she directs the Grace Center at the University of Washington. We're talking today about her book, A Terrible Strength, The Hidden Crisis of the Black Womb and Your Survival Guide to Healing. Dr. Doll, welcome to the Visible Voices podcast.
Thank you so much for having me, Resa. I'm very happy to be here.
The book itself, I'm wondering if you can grab it and show it to the audience.
Yeah, this is my
Walk us through the cover, the title, and the color palette.
My gosh. Can you tell I love it? First of all, I love it. I love it so much. So the cover. First of all, maybe I should start with the title. So the title was very organic. So meaning it came out of a conversation I was having actually with my literary agent. And we were going back and forth just talking about all of the stories that you hear about Black women and surviving terrible conditions, situations in healthcare. And I don't even remember what the specific story was, but I remember as we were talking, I said back to her, I said, Black women really are strong, but it's a terrible strength. And she said, is that the title of the book? Because she's good at her job. And I said, oh my gosh, maybe. And so we it was like the working title from that point on, but it just stuck because it always was relevant. Like anytime I was writing, I was like, this is the same theme I'm writing about, this idea of a terrible strength. So that's where the title comes from. In terms of the cover, I remember I got the email from my team, like, what are your thoughts? We're starting to think about the cover from the publishers, like, send us any thoughts you had. They had like a couple of questions in their email, and Resa, I sent them back a 3-page document. I went to the bookstore. I was like,
As one does.
Okay. Taking pictures of books. Like I was like, this is the section this book will probably be in. And this is what I do not want. And it was like this. Like I was like color swatching things online. Like this is the general. So I knew there was going to be purple because that's my favorite color. And I kind of gave them a lot of ideas about like what I wanted to evoke. Actually, the other 2 books that were my inspiration are up on my shelf. So they had that. And then they sent me kind of like the first set of a lot of different takes. And one of them had a body on the cover. And what was funny was that I had essentially actually said, like, I don't want a person on the cover because, and I think you'll appreciate this, I didn't want the cover to repel anybody by thinking, oh, that's not me. Because I think once you draw a human body, then people are like, or you draw a woman, it's so easy for somebody to see some aspect of that and feel like it's not me. So I really loved what they did because they gave that kind of vibe of the body, which this is very much about, but it's so open and it's so porous in a way. And I love how it kind of evokes this sense of layers, which we talked about a lot with the book. Like this book has like one layer and then you peel back and we're actually talking about something else. And then we're actually talking about something else.
The table of contents, you open it up and you focus on 4 main, we'll say, diagnoses: heavy menstrual bleeding, endometriosis, fibroids, and uterine cancer. And as a prelude to discussing those, you share a bit of your own story. So part of this book is memoir. And in that way, you lead the reader, bring the reader along to why you started focusing on these specific diagnoses. So you and I were talking off camera before I pressed start. One specific story that hit me, and I shared with you that it hit me because it happened during residency, medical training at a top tier training program in OBGYN, which you chose. It was your first choice to go.
Yes.
And it was a specific example of people think that they're allies. And then all of a sudden, when things come before them, they really don't step up, upstand, and act as allies.
It's so funny because when I read it back, it's like such a small, in some ways, it's like such a small moment. In other ways, it's such a common story of like, of this sense, at least I would say as a Black trainee and person in medicine, this sense of like everybody wants to do the right thing. We want to be pro-equity and pro-diversity and pro-inclusion. But then like when it comes down to the actions that are required, that are needed to support those ideals, all of a sudden like that, the passion, the commitment, et cetera, can falter so quickly. And so the story I share is like basically a story of that. I just happened to be at the center of it. And I think why it impacted me so much was that it wasn't the only time this happened, but I was like plucked and recruited, right, to be the leader of this effort to increase the diversity or to sustain the increased diversity of the program. And then upon putting me on that pedestal, when the resistance and when some of the vitriol came at me for doing that, there was no protection. And that is why I told the story, first of all, to explain what it's like to be a Black woman who is recruited or seen as a strong voice, right? You're the person to lead this. But then when you get attacked, that same strength is supposedly evidence that you don't need help or you don't need support. So first of all, as the metaphor of the book, it was very appropriate. But second of all, I hoped that it did almost in the banality and like the mundane nature of how common this is. I hoped I was able to demonstrate to white allies, to other people reading the book, how it feels to be the person in that situation. And then to have people come up to you afterwards and tell you, well, I thought that what you said made sense, or I was really with you. It's just, it's so hard to express how frustrating that is and how common of an experience it is. And it makes me want to, probe the white allies and say, like, what you need to ask yourself about this allegiance that you have to comfort, this allegiance that you have to nicety, to politeness, to whatever, that in whatever the moment is more important than courage or is more important than standing for your values, because it's a consistent issue that we see in certainly academic medicine spaces, but certainly other spaces as well.
In academic papers, it's been described as the minority tax. And you give a very clear example in that story. And to that end, now people may wonder, or listeners, who is this book for? Who did you write this book for?
So many people. And my publishers hate that answer because, you're supposed to have an answer. I chiefly wrote this for Black women who have a uterus. I mean, literally, because I recognize that there's so much dialogue and so little of it feels like it is specifically oriented towards us. And I get a lot of feedback from the book. People are like, I thought I was just reading this, because I should be informed, but I feel like this was helpful for me too. Like, I feel like every woman should read this. And I tell them, like, I agree. I put Black womb on the cover because so rarely is something specifically named for us in this arena, but it is for everyone. So there's that level of it, of just having people feel like somebody is speaking to me and educating me and helping me navigate my gynecologic health. I also wrote this for my colleagues and for trainees. I wrote it because if I went through this journey of not recognizing my own suffering, but also that of my community, and I had to kind of unlearn things and rework things in my mind, I know I'm not the only one. So I wanted to write this for other physicians, for people who take care of Black women, to say, hey, these are all the ways that we can miss what's going on right in front of us, that these are all the ways that Black women are not legible to us because of how we've been trained or how we've been taught. So I wrote it for trainees and I wrote it for my colleagues. I think I wrote it for high achieving women. Like women who see themselves in the story of like being so passionate and committed to what you feel is important, and being an example of what it looks like to go after that thing or share that thing in like your unique way, I think that that's part of it too.
I want to circle back to this concept of tax, and in this sense, the pink tax. People may or may not be familiar with the pink tax. And it is a phenomenon whereby common products and services are marketed to women, ranging from razors, soaps, dry cleaning, and they often cost more than products marketed to men simply because they're being marketed to women. And flipping that on its head, in the book, you talk about procedures. And this is a direct quote. In fact, procedures specific to female reproductive anatomy are systematically reimbursed lower than male-specific procedures. This is just mint. Getting into the financial data on this will enrage you. A doctor gets 45% more money to biopsy a penis than to biopsy a vagina. They get nearly 150% more to remove a lesion on the penis than to remove a lesion in the vagina.
It is wild. And it's so, okay, so what's hilarious about that is, first of all, I'm pretty sure like that's like a footnote. because I can tell you as a gynecologist,
You can tell I read the book.
You swim in this world so much that like that is just like, oh yeah, that's what it's like. You're used to being devalued as a specialty. Like I remember my mentors being aghast that I even chose OBGYN. They were like, come on, like you got to do neurosurgery. You should do like, it was just like, it was so sad when I think back on it. Like, why do we devalue women's health so much that even within medicine, my field is looked down upon? So when you start to learn about, oh yeah, we like make less money, that just also becomes like the sea you swim in. And so I wanted to include that because part of this book is humanizing gynecologists to patients too. I'm trying to humanize us as the people in the field dealing with what we deal with. But yes, it's so interesting to think about the fact that if something is marketed to women, we want women to pay more for it because look how like we have to put extra effort into caring about you. But then a procedure done on a woman to help a woman is reimbursed lower because we don't actually value women's health. I mean, I actually think they're consistent actions because they both say we don't value the humanity of women. Women, like we value what we can get out of women. That's what we value.
That's exactly it. So emergency medicine and lifestyle medicine, as I shared, I was delighted that in the book, you actually covered quite a bit of lifestyle medicine, behaviors and actions that people can take. So specifically in your section on fibroids, you really lay out a holistic approach to care that includes diet. And discuss a little bit about diet and fibroids.
If I could just say, this was really important to me to do. And I want to credit my editor for really, it was kind of hidden in the first drafts of the book. And she was like, I can tell that you have this tension, that you want to talk about this stuff more. What's going on there? And I expressed to her how, it is frustrating to me that we live in this right now. The dialogue feels really us versus them with some of this, like the lifestyle medicine, the behavioral versus like quote unquote, right? The hard evidence-based randomized controlled trials, et cetera. So as you already know, Resa, that is a scam. Like the idea that there's this dichotomy is a scam because we have these wonderful trials that look at behavior, that look at diet, that look at these other things. And I wanted to share with people in a scientific book that all of this can exist in the same place. So fibroids, personally, I have fibroids. Like I wanted to learn, what do we know? What do we really know about the kinds of risk factors and things that we can do? Because as a gynecologist, let me tell you something. For us, it's just like, listen, they grow. When they become a problem, do something about it. That's it. So things I learned predominantly from the Black Women's Health Study, which is also something I try to emphasize in this idea that we don't have any evidence we do, is that diet does matter. So diets that have a high glycemic index, so a lot of simple sugars, simple carbohydrates, and as you know, right, like not a lot of complex carbohydrates, protein-focused diets, like things that are more your blood sugar is spiking up and it's spiking down. That kind of diet is associated with increased fibroid prevalence and growth. Alcohol is associated with increased fibroid, which every time I tell that in a crowd, everybody just goes, I'm like, I know, I'm sorry to tell you,
so
but
sorry.
like, I am so sorry to tell you. Beer is kind of the worst offender, but still. So that's something that is important. You mentioned already, diets rich in vitamin D. So like vitamin D supplementation and calcium supplementation also are preventative against fibroids and also have some action in like stabilizing fibroid growth, which I think is really important for the folks who already have them. The thing that is very controversial in the fibroid world, I'm kind of curious what you think about this, is this whole idea of like veganism and dairy and inflammation, et cetera. So I came into this book assuming vegan diets are good for fibroids because of how common I heard about that. I heard about this it was just like, oh yeah, I went vegan because da da da. So I just assumed that the data backed it up. And so I was like a little aghast when I was reading into the literature and I was like, y'all, that's not what this literature says. So because, actually dairy is protective against fibroids among Black women. And we do think it's probably because of the calcium. Like it's probably not the specifics of the fact that you have dairy, but I feel like that's important. There's also a narrative about soy being bad for fibroids. That's not true. That is not borne out in the studies that have looked at this directly. Meat is also a big piece of the discussion around fibroids. And, I was surprised by this as well, but like red meat, poultry, these things are not related to fibroid growth. The only thing that's been found is actually fish, which is odd because of how we think about omega-3s being anti-inflammatory. So I will say that the authors of that study really grappled with like, how does this make biological sense that we're seeing more of a risk factor of fibroids in those who have more fish intake? And they have thoughts actually about the contamination of the fish. So they have thoughts about like whether this is about the sourcing of the fish that people are eating and like where it's coming from in terms of freshwater versus saltwater, stuff like that. So I just wanted to honor the fact that they're in scientific like dialogue and curiosity about why this finding is there, but it is there. So those are some of the things that I like to share with people about fibroids and diet.
Thanks for those. And what I'll say is in my own work and, diving into the literature, what I'll say is soy really has gotten historically a bad rap, and
Yes.
it hasn't borne out in terms of what you
No,
shared with fibroids or with breast cancer. And when I
exactly.
look at some of the studies that look at vegan diets,
Mhm.
I make a particular note to see if, processed vegan is just as bad as other processed foods.
Yes.
Are people eating
Yeah.
ultra processed vegan meats,
Yeah.
ultra processed vegan foods that are just as bad
Yeah.
as just, the predominantly whole food, minimally processed
Yeah.
vegan foods?
I think about that too as well. Like I think, we're getting first of all, diet studies are difficult, first of all. And actually, a very maligned study, the Women's Health Initiative, which I think is unfairly maligned, but it is a maligned study. They actually demonstrated how hard it is to get people to get accurate reporting of what people eat. And just because we ourselves are so bad about it, even when we're trying, they have a really interesting study comparing kind of caloric intake and people's report versus what they actually took in. However, what I'll say is that I recognize that diet studies are difficult and we're getting better at it. But it's like you said, it's like every time we kind of get to a point where we're like, okay, now we're going to really study like what's going on with vegan diets, et cetera, then this other world comes around where it's like, well, in the past 10 years, we have an explosion of Beyond Meat and Impossible Burgers and all these things. How does that compare? So it's just not as easy as it seems. And lastly, though some of these studies, not all of them, unfortunately, some of them try to account for the socioeconomics and the access issues with comparing these things. Most of them are woefully inadequate in thinking. So, like, if you're on a vegan diet in a food desert, you're eating potato chips. Like you don't have you're not on a vegan diet and having this incredible plethora of like a cornucopia of fruits and vegetables and all this. Whereas if you're on a vegan diet and in an area where you have whole foods and you have farmers markets and you have all of that, your vegan diet looks very different. And so these are also issues that I suspect that are hard right now to disentangle in some of these dietary studies.
Same. When I think back to how we first met, it was on social media. And it was me watching your clips from your podcast and showing sort of a day in the life of Kemi. And you often showed yourself doing weights, doing exercises, maybe doing burpees for some reason I recall seeing. And I bring that up because another lifestyle pillar is vigorous exercise. And you talked about that also with fibroids.
Yeah, so fibroids definitely are sensitive to exercise level. Moderate exercise, I think it's at least 2 hours a week, a minimum of 2 hours a week. I think 4 hours is better than 2 hours. It's the same thing, right? 6 hours is probably better than 4 hours, and then at some point it tapers off. However, that also decreases risk of fibroids. And so this fits in with what we think about when we think about why exercise is so beneficial for the body. I mean, movement is medicine, as we say all the time. We have study after study. I'm not sure that we have studies that demonstrate exercise is bad for anything, honestly. Like it is sleep, mood, everything. So to me, it makes sense that fibroids fits into that paradigm, that it improves things. I will say, sadly, I can't even do burpees anymore because I had a knee injury. So now, and I just wanted to say this for people listening, my predominant exercise is walking and brisk walking because it has to be brisk to get to get your heart rate up and all those things. But there are lots of different ways to get to that threshold of the moderate to vigorous exercise that does not have to be high impact necessarily. And so that is included in those different definitions. But yes, exercise is, of course, great.
These lifestyle medicine pillars, we talked about food, we talked about exercise.
Yeah.
You mentioned two that I think are two with which a lot of physicians struggle: sleep
Oof.
and stress/stress reduction.
Yes. This is so funny you brought this up because I was just thinking about this yesterday. I was just thinking about how many physicians, because most physicians are in practice full time, vast majority, right? Most academic physicians are also in practice the majority of time, even if they do other things, vast majority. So when I talk about pretty much all physicians, how many physicians do you think would say that their schedule and the work that they are contracted to do, that they are supposed to do, the expectations that on them allow them to, one, get the amount of sleep that is recommended at a baseline for just like general health, or number two, have the kind of stress levels that we would recommend for people in terms of like minimizing chronic stress, minimizing stressful situations, etc. Like, it's just, I do wonder Resa, if that makes our work to help patients harder, because like, how does it feel for you to tell people, oh, you really need to get enough sleep at night? And you're like, I don't know how, girl. Like, I mean, like, it's hard to speak with conviction when you also are like, I mean, this is probably not really realistic because in our world, it rarely is realistic. And so like, I only started getting good sleep hygiene when I went part-time. Like, and the thing is, I have a full-time life, but going part-time and then allowing the other endeavors I do to pay the other part of my income gave me enough flexibility to be able to enact this healthy lifestyle. So it's just, I don't have an answer. I'm just saying it out loud. Like, how many physicians can do this? Yet we know how critical sleep and stress are.
Yeah. And I bring it up actually for this exact reason.
Okay.
Medicine does not teach us, does not model physicians taking care of themselves.
Not at all.
And and in fact, we're often not taught basics of lifestyle medicine, including food and food as medicine, such that I actually recently gave a lecture on teaching physicians about lifestyle medicine. Everybody's like, don't doctors know all this? No, doctors have the same exact chronic diseases, same rates as our patients.
If
In
not
terms
worse,
of obesity, if not worse.
if not
Yeah.
worse, depending on, and not only that, doctors have higher substance abuse. Doctors with access, because that's the thing that's so incredible to me. All it takes is access. Like, anesthesiologists have more trouble just because they have access to the meds. Like, it would be all of us. If we all had access to the meds, it would be all of us. And that really tells you how the field is not set up for the wellness of the people in it. And yet, I also say this, because I say this to trainees all the time, because I think trainees are some of the number one people who are like sounding the alarm, right? They're like, hey, this doesn't make sense. Like, I'm here stressed, a burnout husk, and you're asking me to work. And I tell them, yeah, because the job that you're going into is asking the same thing. And again, this is a place where I don't have an answer, but I'm not sure. I don't know about the idea of fixing training and not fixing the field. Like, I don't get that, because as you know, you and I know, somebody full time in medicine does not get mental health days. They do not get time to go to the therapist. They do not get, like, none of these things exist in the actual field. So yeah, it's a real disconnect right now.
Your book,
Yeah, back
you've
to the
read
book.
stories, individuals that to illustrate the topics on which you focus. And I want to bring us to endometrial cancer and awareness. Endometrial cancer is the most common gynecological cancer in the United States, more common than ovarian, cervical, even colon. Yet most people have never ever heard of it until diagnosis.
Yeah, to me, this is directly related to the conversation we talked about with not caring about women and women's health. It's the only explanation I have for why people know about colon cancer, but they don't know about endometrial cancer. And it's also, And I think it's a product of the devaluing of OBGYN, within which is where gynecologic oncology lives, not in the broader oncology community. The fact that we have generally silencing around the things that happen below the belt, and also the way that racism is laced into our field and our society, because for a long time, up until pretty recently, most white women who got endometrial cancer had very, very favorable prognosis and essentially were cured with a hysterectomy alone. And so it becomes this kind of like silent epidemic that is treated with a hysterectomy that nobody really has to talk about. And it didn't matter that Black women didn't have that story, that we were more likely to be diagnosed at later stages, had more aggressive types that did not respond as much to chemotherapy or hormonal treatment, etc. And that is unfortunate, because now that endometrial cancer is just, again, it is the second fastest rising cancer in the country right now, which is wild. And it's the only one that's rising alongside the mortality rate. So it's not just about increased diagnosis. Also, the mortality rate is rising because those more aggressive types are on the rise. And we are caught on our back foot. We're caught like, oh no, because we haven't put the same amount of resources, scientific studies, clinical trials, et cetera, into these more aggressive types of endometrial cancers that Black women have been dying from since the 1970s. So we're playing catch up now, but I think that those are some of the reasons why it's just now getting a little bit more recognition, why there was no advocacy group for endometrial cancer nationally recognized until we started ECANA in 2017. And like I said, I'm glad that it's changing, but I guess maybe where I'll land, it's a reminder that we're humans here in medicine, and our medicine exists within our society. And it's not just that we see some of these biases and like consequences of racism on like one-on-one personal levels, even the hospital level, but we see racism and sexism on the field level when we look at things like what is being funded and why, who is talking about what cancers and why. Because I'm with you. Every time I talk about endometrial cancer, people are like, they have that look on their face like, what? Like, how is it possible I don't know
Isn't it
about this?
breast? Isn't it
Isn't it
breast?
breast? And I'm just
Because
like,
there's the pink campaign, the
there's
big
the yes,
ribbons,
we
a
have
lot,
all of that. Well, and I think also because men are more comfortable talking about breast. Men are
Mhm.
happy to talk about breasts. They don't want to talk about. I feel like that is a huge part of it. I know breast cancer is also more common, but I think that is a big part of it. And like, it's just very interesting to me the difference between that and like, okay, but can we talk about bleeding? And it's like, oh no, nobody wants to
Yeah,
hear about that.
it's true. And in fact, I recently read studies where menstrual blood is a source of sampling and of study, not just blood, not just sputum, not just.
Yeah, and also like diagnostics. It's like, wait a
Mhm.
minute. If blood is coming out of this organ and there are things that going on in this organ that we're trying to figure out, wouldn't it be amazing if we could use that blood to figure out what's going on inside? So that
100%.
stuff is underway, which is great. And I
Yeah.
mean, it is also it's underway. So like it has to get better and better. Diagnostic testing is really difficult, as you know. There's so much signal to noise, but I think it's so promising what we might be able to get out of that research, especially because of how unique of a space the endometrium is in the body. It is just as protected as the brain. It is like a very protected space in the body. So there's a lot of uniqueness about that space. It's why it's hard to treat conditions there, but it's also why there's a lot of scientific possibility there.
Your enthusiasm for the womb is infectious.
Yes. Another goal.
You know, your book is really also a patient advocacy book,
Yes.
and you want the reader to be empowered to take better care of themselves or to learn how to take better care of themselves, to ask better questions. So I want to move to talking about some micro skills, some small actions that listeners can take. For people listening, if it's someone with a uterus or someone who knows someone or lives with someone with a uterus, what's one thing they can do at their next visit with a gynecologist, with a primary care physician, to better advocate for themselves? Is there one question they can ask at their next visit?
One question that I like to open up a conversation is actually the question of, I'm curious how we can optimize my womb health, because it gives you a lot of information. One, it opens you up to say, is my doctor even thinking about this? Is it on their radar at all? If their answer is I don't know, that's okay, because it's like, okay, good. You need another doctor. Maybe you go to a PCP who's like, I'm not thinking about this at all, and you need to go ahead and go to a gynecologist. Maybe you go to a gynecologist that is still only in the mode of, I just treat problems. And it's like, okay, so maybe there could be a better person for you, or that person, you can click them into that more prevention, holistic framework instead of just looking at you and wondering if there's a problem or not. So I really like that question. The other thing is that the answer makes it clear how much there is to think about. Because then the answer to that question could be, okay, well, if you're in your reproductive years, have we actually talked about whether your cycles are normal or not? Do you even know the parameters of normal, which again, Resa, most people don't. I'm like, everybody gets a period. Everybody knows about the products. And then I say, okay, so what's the normal period? How long should it last? Blank spaces, right? How much bleeding should you have? Nobody knows. So like it opens up that question. And for the perimenopausal and menopausal physicians, it opens up the question of what does health for the womb look like? Not just your hot flashes, not just your hair loss. What about the organ itself? And that can get us into risk factors, family history, all of these things. I had somebody ask me, they're like, well, I forgot their question. Oh, it was like they had a family member that was like older, and I can't remember whether she had dementia or not. I can't remember. But they were like, she's had some bleeding issues, but we've just been using diapers. Like, does she really need to go to a gynecologist? Like about that. And I was like, yes. And it was so disturbing to me because they were like, well, does it really matter? And I'm like, well, do you know how often that vulvar, vaginal, uterine cancer is diagnosed in an older woman who nobody's paying attention to what's going on down there? And we're the first ones to do an exam and say, like, your loved one has an untreated cancer. So like, I'm not trying to scare people, but like, why do we do that?
Well, there's no examination. You already mentioned this, below the belt, below the belly button. Don't look, don't examine, but also, oh, it must be a hemorrhoid, or oh, it must be a UTI. Like it must be coming out a different orifice.
Yes, it's just probably a UTI. Oh, we see that a lot in endometrial cancer too. Like, oh, I was treated 6 times for a UTI because of blood in my urine. And I'm like, do we know it was in your, did anybody actually assure you that it came from your bladder and not the vagina? And it's just like a non-question, going back to the misogyny and the sexism in medicine, which we learn, I feel like, in medical school. And really, honestly, I would say more so in residency training. It's like, that's somebody else's problem. That's somebody else's problem.
You led me right into the next micro skills. For the doctors and other healthcare professionals listening, what's one thing that people can do to be better doctors in this space and to better resist the indoctrination that we get in medicine?
One, recognize that there is indoctrination and it is not a personal judgment on you. We're such an individualistic society. It's like, I think sometimes it's hard for us to just acknowledge we are a product of our environments and that's not your fault, but we do have a responsibility to be aware of it. The second thing, which is something, as you know, I detail in the book, is like changing the way you ask questions. A lot of times we ask questions that are like, do you have a problem? Basically. Is this a problem for you? Is this bad for you? Is this whatever? When you're dealing with people who aren't allowed to have problems, who are like, my whole life I've had problems that I've just had to deal with, the threshold of me coming to you to say, hey, please help me, this is a problem, is way higher than it should be, which means that as a physician, you can't wait for that. It has to be something different. Like, this is what normal is. Does this match what you're experiencing? It has to be something different. So I think we need to be more curious about people in terms of thinking about not just are they struggling, but how are they adapting in order to keep functioning? Because that's a more important question, especially for anybody on the margins. How do you have to adapt in order to go to work? How do you have to adapt in order, to take this flight or whatever, as opposed to just, is this a problem for you? The last thing, which I know is not easy because it's frustrating to sit with a patient and want to help them and have them say essentially no. Like, I don't want this help. And you're just like, why are you here then? I don't understand. What I want to explain, hopefully if you read the book, you understand that actually truly better. Like, you really actually understand the human who would go in and listen to you and be like, yeah, no, as opposed to just thinking that they're dumb or ignorant. There's a reason why I profiled smart, achieving, fantastic women in the book, because I wanted to show what they go through. But also, it's just to recognize that actually, if somebody is telling you no to your face, there's an element of trust there. You've built a relationship. Because if I really don't care and I really never want to see you again and I have no trust in you, I'll just lie to your face. You'll give me a prescription and I'll smile and nod and I'll walk out and throw it in the trash and keep moving. The fact that somebody is like, I hear what you're saying, but I don't know. I don't want this. That's like, okay, thank you. And I want doctors to instead respond, thank you for trusting me enough to say no. When do you want to talk about this again? Because I want the best for you. Yeah, it's just a reframe. Thank you for that. Oh, that for a patient, they're like, oh, it's like, yeah, you matter. I appreciate you. When do you want to talk about this again?
Your share of a response is a fantastic reframe. It's a great reframe for the physicians that counter-transfer and get angry at the patient for not listening to them because of the hierarchy and the paternalistic, patronizing nature of
Patronizing.
medicine.
I agree completely. Like, you're tired of everybody telling you what to do. You can't imagine that now you're telling somebody what to do and they won't listen to you. It goes back to Resa. We're humans. Like, we are not robots. We're not above any of these things. We are actually deeply in it. You know what I think is interesting? You know how people in mental health professions, so licensed clinical therapists, almost all they have therapists, because one of the things that they learn to their core, right, is that, listen, like, you will counter transfer on a patient, you will bring your own stuff into the room, so like, you need to have a therapist to help you not do that with your patients. We don't do that as doctors, right? We don't say, hey, listen, you're going to bring all your stuff into the room, so who do you go to make sure that you don't do that? Which, if you think about what we deal with people, is wild, that there is like no norm in that. So I appreciate you bringing that up. And I hope that, I guess I'll say, from a writer's perspective of the book, knowing my colleagues would read it, I hope it comes through that I am humanizing us. I'm not demonizing us. And that I hope it feels like, oh, I have more tools. And she really is showing what we go through, not just like, oh, the bad doctors who don't care about you.
To take this time to call out something that you were instrumental in changing, and that's some ACOG guidelines and the endometrial stripe.
Yeah. I tell people I was a researcher that was focused on like solving the problem. Like, I was apathetic to the method. I was like, I don't care what the method is. This is the issue that I see. And one of the issues was this consistent, persistent advanced stage of diagnosis for Black women with endometrial cancer. And I learned about it that it was just secondary to the fact that Black women have more aggressive types. So their cancer grows faster. That's the issue. Well, actually looking at the cancer registry data that we have, both within health systems across states, we see that that is not true. That, it independent of this histology difference issue, we see more delayed diagnoses. So my research just kind of started in this: what are all the reasons why Black women are dying more of endometrial cancer? And I did not suspect the guidelines being an issue at all, to be clear. I just thought the issue was access to care. Black women are not getting the appropriate diagnostic procedures when they're coming in reporting bleeding. So that's true. That was not happening, even Black women who were insured across national data sets in Medicare, et cetera. But in addition, what we also saw was that, but this is really odd because Black women who are getting ultrasounds are still not, they're having these long delays before they get biopsies. They're still being diagnosed later. And then women, when we interviewed them, would tell me, I got an ultrasound and they just told me it was my fibroids. So that led to this question of, we had a paradigm that said, in order to save women from a painful biopsy, if they come in with postmenopausal bleeding, you can do an ultrasound, measure the endometrial stripe or the thickness of the endometrial lining. And if that is less than a certain threshold, the most commonly endorsed was 4 millimeters, then there was a 99 to 100% negative predictive value that they would not have endometrial cancer. So you do not need to do a biopsy. So I want to be clear about this. This is a guideline that stops the diagnostic process. It says you don't need to look at this anymore. It is not cancer. That's the guideline. Okay. 99 to 100% predictive value. That data was from Scandinavian countries, Hong Kong, and Italy. That data, half of those studies excluded women with fibroids altogether, and the other half did not include Black women. Black women have an 80% prevalence of fibroids. Black women also have a 30% prevalence of the high-risk histology types that are least likely to be picked up on ultrasound. So what we were able to demonstrate with my research is that this guideline systematically underperforms for Black women, systematically misses endometrial cancers in Black women who get to the point of actually presenting with a symptom to be falsely reassured, which is a major issue when you think about how long it would take you to come back after you've been told the ultrasound said everything is okay. So ACOG, we've been publishing on this since 2021. I've been presenting on it since 2020, the data. This year, 2026. In addition to other groups that similarly found issues with the ultrasound threshold, I should say, because I do think it's important that you get scientific consensus. In 2026, ACOG has now changed those guidelines to indicate that we should actually have a risk-based approach with transvaginal ultrasound screening. And so that if anybody has any of the risk factors for endometrial cancer, you must also do a biopsy when they present with the cardinal sign of endometrial cancer, which I'm really grateful for.
Nice work, Dr. Dole.
Thank you.
When did you realize you had a voice and when did you start using your voice?
I realized I had a voice early on. probably by middle school, because I felt like I had like this outsized impact when I spoke that I did not understand. So I would say the same thing somebody else said, but I would get in trouble or I would be listened to or in a way that honestly was not good at that time. Like I felt like it opened me up for ridicule and things like that. And so I remember when I went to 8th grade, I literally wrote in my journal, like, I will be quiet. My goal was to be quiet and be in the back and just be like, speak when spoken to. That I like made myself a commitment to do that. It of course lasted about 48 hours, but I just say that because I would say that was like, I recognize, like, I cannot just be out here talking. Like, I have to shut up. But you asked when I started using it, and that's different. So I feel like I started using my voice probably toward the end of residency, when I did a grand rounds on the impact of surgical volume on outcomes in gynecology, in a place where I knew that one of the issues we had was people that had very, very low volumes taking people to surgery in a way that was not the safest. And I think, like, when I think back and the fact that I was like, that was my choice of my senior grand rounds, I said, Kemi. So there was like, that was probably the beginning of kind of tiptoeing into, I'm going to say the thing. I'm actually going to say the thing. And it probably came out of because I had more clinical confidence. Like I had these other markers of like, I know what I'm talking about. And then, probably when I really deliberately got on social media. So when I joined like Twitter, like when I joined these platforms to start specifically saying things is probably when I was like, okay, I'm actually going to use my voice specifically.
Dr. Kemi Doll, thank you so much for joining me on the Visible Voices podcast.
Thank you. This was a pleasure.
The Visible Voices podcast amplifies voices in the healthcare, equity, and innovation spaces. Our team includes Dr. Giuliano DePortu and me, Dr. Resa E. Lewis. Find me at Resa E. Lewis, MD on social media, or visit thevisiblevoicespodcast.com. Find us wherever you listen to podcasts and watch our episodes on YouTube. This podcast is for education and entertainment purposes only. The views and opinions expressed by hosts and guests are their own and do not reflect those of their employers or institutions. Guest appearances do not imply endorsement of any product, service, or organization. Information shared here is intended for general informational purposes only, reflects the time of recording, and should never substitute for clinical judgment or individualized medical advice. No physician-patient relationship is created by listening to or watching this podcast. Together, we're making healthcare more equitable, one visible voice at a time.